Good. What do you think, Khalid? Do
Yeah,
we
I think we
we've
can
got a
start.
quorum?
A good quorum, yeah.
So yeah, I am happy to be your guest today, and this is a place where we get to discuss supervision, and I happen to have written a book about supervision, so I'm happy to hear what people are wanting to deal with. Do you want to do cases? Do you want to talk about my book? What would be good for everybody?
I think we would love to hear about your book. So if you could walk us through probably how did you come up with the idea and then what is the book about? I think that'd be great.
I'll be happy to do that. Who has
Yes.
not read the book? I know several of you have. Oh, good.
I have the book. I have not yet finished. So
Okay. So for the people who haven't read the book, let me just give you the 2-minute summary. This is a book about a year-long journey between a senior child psychiatry supervisor and his supervisee, who's a first-year child psychiatry fellow. And the format of the book is every chapter is a supervision session. So it spans a year. So the first supervision is July 15th, and the next one is July 22nd, and the next one is, and so on. And it is a discussion of the supervision, and it provides my model of supervision I've been doing for 50 years. For those of you who've known me for longer, there's no surprise here. This is the way I have supervised, and so that's why it would be a good topic to discuss here. It's called One Long Supervision, because One Long Conversation, because it is a book that has essentially no narration. It's all conversation, the conversation between the supervisor and the supervisee. They do co-therapy together with families that they see in videotape. So there's the conversation of the families and the therapist talking with the families. And then there's an internal monologue session where the senior supervisor talks to himself. So it's all conversation, and it happens to be consistent with my view of the world, which is that we co-create our realities through the interpersonal relationships we have and the conversations we have with the people we know and the people we don't know, and that this is how we as psychiatrists interface with the world. We talk to people, we listen to people. We have conversations. So I got the title. My wife actually provided the title for me. She was helping me during the editing process, and she said, "Oh, this is just one long conversation." And I said, "Yes, that's it. We'll call it One Long Conversation." Okay, so Khalid asked a little bit about where the idea came from, and some of you may have heard this. I know Betsy has. A couple of years ago, Family Process had a 60th year reunion, marking the 60th year of the publication of Family Process, and I was on the board at the time. Betsy was there, and one of our friends heard that I had recently just retired, like a month before, and asked, "What are you going to do now?" Oh, no, what she said was, "What are you going to write?" As if the only thing you would do if you were retired would be to write more. Because that's what academics, they never have enough time to write. So she said, "What are you going to write more? What are you going to write?" And I thought, and I said, "Well, what I really would like to write is a novel. I've always wanted to write a novel." And so then the next question was, what am I going to write about? And the old saw, you write about what you know. And what do I know? I know about family therapy supervision. So I'll write about family therapy supervision. And then after that, the format of the book and the the idea of having it be supervision sessions between a senior supervisor and a supervisee sort of jumped off the page, and from there I was off and running. So yeah, and I had a lot of fun doing it. And it came out earlier this year. And I can't say it's reached the bestseller list, but people are reading it, people are buying it. That's good.
I have a question, Tom.
Yeah.
Would you say the narrative that you share in this book, is that a reflection of the shared realities you've created supervising many supervisees, or is this more reflecting of one particular relationship?
No, it's a conglomerate. I've supervised hundreds of supervisees over the years, and I didn't model this after one particular person. But so, and likewise, during the course of the book, I give examples of different kids and families that I treat, and people ask me, well, is that, did you just copy a videotape you made, 3 years ago? And no, I've treated lots of acting out teenagers. I've treated lots of eating disorder kids. I've treated lots of psychotic people. I've treated lots of domestic abuse situations, all of which show up in the book. And so all of the stories are composite stories of families that I've seen. And you all could do the same thing. I mean, you've all, these, when you read these clinical vignettes, those of you who've read the book, Betsy, you've been there. You've seen these people that I'm talking about. They're all they live in our everyday experiences as child psychiatrists.
So, Tom, for me, as like a early career, aspiring family psychiatrist, if you will, it sounds like there could be lessons to take away from all kinds of varying family, situations that you've seen in your career, basically. Yeah.
That's true. One of my messages in the book is that as child psychiatrists, we need to be curious, and that we will learn more from our people we treat than they ever learn from us. And I think that's true. Most of what I've learned over the years has been imparted by people that I know as part of that conversation that I've been having literally since 1972, when I finished medical school. So what other questions do people have? And yeah, Nora?
I have a question, but it looks like Andy's got his hand up, so I want to let him go first.
Oh, yeah.
Where'd Andy go? There he is. Okay.
Excuse me. I'm still here. Yeah, I was gonna ask a general question. I've not gotten to read the book, so I'm excited to. I love the premise of it. When you were describing about sort of creating and experiencing our reality through our shared sort of collective interpersonal experiences, I wondered about what I guess would be labeled cultural factors and how you address that. What you just said about being curious and learning from the families we work with, I heard as part of that, but I wondered, maybe especially with supervisees and also with families, are there ways that you explicitly inquire or name what differences there might be, not just in our experiences, but in our worldviews based on, gender, ethnicity, race, culture, language, etc.? Or does that come up more organically? And do you have thoughts about how we might best do that when I'm meeting with a supervisee for the first time, whether how much to disclose, what's fair to ask of them that might inform this dialogue we sort of have in supervision, and then the same parallel with families and patients about how to invite that information as relevant, but not always visible or obvious?
Well, I don't know quite how to respond because I think you summarized things pretty well. Literally, it's important to realize that the people sitting, both our supervisees and the people who we're working with, are not us. They have their lives, and we've been invited to essentially share their lives. And that means people who come from different cultural backgrounds, different ages. Priya. Oh, okay, good. Picture. Oh, somebody joining our group.
Yes.
There she is. Hi. Welcome. So Andy, to answer your question, being open and honest and communicating honestly means acknowledging differences and celebrating differences, and that extends not just between supervisor and supervisee. One of the themes of my book is this difference between being 29, 30 and being 75, being at the end of my career, end of the protagonist's career, and being at the beginning of a career, being and the contrast between those two points of view of the world. I mean, it's yes, I can remember much of what it was like when I was doing my child psychiatry fellowship. For those of you who don't know, Betsy certainly does. I did my fellowship at Philadelphia Child Guidance Clinic with Sal Minuchin and Jay Haley and a cast of grand old pioneers. And I certainly remember what it was like to be supervised. But a lot of time has gone by since then, and people who are 30 now have a totally different world than the one I grew up in. So it's for me to learn from them and to have them help me with my computer on occasion, which has been done many times.
Could I follow up a question or a comment or a thought or a wonder about that? And that is, you talk about families have come to and trust us to work with them, blah, blah, blah. However, I think that was very true in the old days where we had family clinics. But what I'm finding and have found as I've worked in the context of child psychiatry, which I have ever since I left Child Guidance Clinic, is that most times the kids come and the families, it's not a context in which you think about the family coming for help. You have to engage the families to help you to help them. And that's a very different mindset. It requires, among other things, I love the notion of curiosity, because I think wanting to know more from whoever we're working with is the beginning of a building of a relationship of trust. And I want to know. But the problem is a lot of people who go through medical school are trained to expect we know and we'll tell you. And the families and the parents come in, you know, you tell us. So how do you help trainees to overcome that need to be the expert because they're being asked to be the expert, and help them to be a more collaborative team with the family?
Betsy, let me give a couple of thoughts about that. One is a systems issue. If you have a clinic and people are coming to your clinic and they're told on the phone, bring your kid, that means that you as the clinician are starting, on your back foot.
Right.
If they're told, and one of the things at Child Guidance Clinic 50 years ago, every family was told that every evaluation starts with the entire family in the room. That was told on the phone, bring your family. So let me fast forward a little bit. Trainees often ask me, who should I invite to the session? And my answer is, I tell people to bring anybody who is part of the problem or would be part of the solution. that's something that I think has stead me and has served me in good stead over the years, because people know. They know who the problem is. Grandma's the problem. Grandma's the one that's getting in the way. She's undermining everything I'm trying to do with my kid. They know who's part of the. They also know who's part of the solution. That it might be the lady next door who does childcare, and so bring everybody who's part of the problem, part of the solution. And I'm not a purist. Carl Whitaker used to say, I won't start a session unless I've got everybody in the room. Anybody remember Carl Whitaker besides us old timers? He was a purist. He would say, oh, Dad's not here. Sorry. Come back next week. And I won't go that far. I will allow people to tell me who they think is important. And if they get there, and they start talking about somebody who's not there, that's an indication that that person probably ought to be in the room. So that's a long, roundabout answer to your question, Betsy, but it is true that we have often been put in a position where we're supposed to follow the wildly conceived medical model, which is treat the patient, forget the family, treat the patient. And those of us in this business and those of us in the room understand that you can't do that. You've got to, a patient doesn't exist, a kid does not exist without a family, either internalized or real. Khalid.
So, Tom, I would love to hear what is the ideal characteristic of a mentor?
Oh, that's a good one. I think we could have a discussion about that. I'm not sure that I have the final word, but I will go back to that notion that I began with, which is an ideal mentor is not someone who feels like he or she has all the answers and can teach everything. It's someone who will meet people where they are. Some of you know that I, for 17 years, ran a day treatment program for families with medical and psychiatric illness. We treated everything that came in the door. We treated encopresis and eating disorders and seizures and the mantra that I got my staff to live by was we always start with where the family is. We always start with where as they walk in the door, we don't make them fit into our mold. We fit into their mold. And I think that's, for a supervisor, I can't see a way out of that. You have to start with what you're working with. So I've had people come into supervision with me who have one of my characters in the book, the supervisor says, well, yeah, my supervisee fired me after 3 sessions. He said I didn't know anything about medication. So I had no use for him. And I've had supervisees like that who can't think that what I have to tell them has any relevance. And I have to respect that. I mean, if that's where they are, then we talk about medication. We talk about, why people don't take their medication, why they, because compliance is 80% of medication management. If people don't take their medicine, it's irrelevant what you write on the prescription or send into the drugstore. So I'll start with that. I think that a good supervisor has to be attuned to the person they're dealing with in an open and honest way, and be willing to. One of my themes of the book is that what we do as therapists is we add to people's story. They bring us their story and we add to it. We we attach a thread to their story. So our supervisees who are coming to us, we need to start with where they are and see where they may be willing to add to their repertoire, add to the way they're conceiving the world.
Before
Yeah.
you ask, Rakin, one quick question, the same kind
Yeah.
of context, before I ask you to ask another question. So it's a, kind of attached to the same question. How a mentor, a good mentor, an ideal mentor, stay mindful of their own inflexibilities as they age, as they become experienced?
Interesting. Okay, I've done this before. You want to do it the way my way I do it. Yeah. Okay. That's a good one. That's a good one. How do you keep open to new ideas, and at the same time, what another one of my themes of my book is that there's always tension between what's gone before and what can come in the future, between conserving what's good and adding something that might be better. And that comes out in change. People come and ask us if we'll help them change. But what they really are saying is, I want to keep everything that I want to keep, and I might be willing to change something. What would that be? And that is that comes to play when people come to you and you say, well, I've seen this problem 17 times and I know the answer, so just let me tell you, and then you can go on your way. And because that doesn't work that way. That's not how people change. That you still have to start with where they are, and you as a supervisor have to be honest with yourself that people don't always want our message. They don't always want to hear what we have to say. So let's have a conversation that starts off with the idea that it's going to go two ways, that it's going to come from me and to me. Who's okay?
Tom, this is Rakin. That was such a amazing question, Khalid, because now I have to add a second question. Building off of Khalid's question, in your mind, what kind of qualities make an optimal mentee? I want to throw that question out. But my original question was also, you in your career, not just as a clinician, but as a supervisor, you've now spanned a couple cultural generations. And I'm curious.
I don't even know what generation we're at now.
I don't know either. I don't know what I am anymore.
I don't even know what the next one is.
And maybe that sums up my generation. We're just confused. But, from your perspective, do you see kind of broadly the culture of family in America changing or shifting? Cultural, like kind of broad parenting values or family values. Do you feel like you felt like kind of a broad shift or changes in your career?
I would say yes and no. I would say that there are certain truths that are continuous. That I think that parents generally love their kids and want them to be happy and to have better lives than they have. And I also think that parents can get frustrated with their kids and feel like there's a tension in why don't my kids just shape up and fly right? And so I think that there are cultural influences. And there are temporal issues and cultural issues, and those are two separate things. There are things that would work 30 years ago that won't work now. That's a temporal issue. And there are things that would work in a white middle-class family that wouldn't work in an Asian immigrant family. I mean, those are the cultural issues and the temporal issues are the things you need to continually keep in mind and be cognizant of. So I think that to get back to your trainee, the mentee, okay, so in my book, the mentee is an idealized mentee. She's smart. She shows up. She doesn't. She challenges me, but she doesn't, give me shit for no reason. She doesn't believe everything I say, but she's willing to be open to new ideas, and she's willing to evolve over the course of a year. She comes in as a dyed-in-the-wool CBT person who says, "Don't think you can give me any of that malarkey," and she leaves at the end of the year feeling like, "Gee, there's something really to this family system stuff." So an ideal mentee has a spine, but is also open. It is willing to do these two things: conserve what's good and be ready to make it better. I mean, does that make sense? I mean, doesn't that pretty much summarize, if you're supervising somebody, isn't that the person you want to walk in the door?
Yeah, it makes sense. And sort of I think what I'm hearing from you is sort of knowing themselves to a degree, being in tune with their values. Maybe I'm hearing you say,
Yeah,
being curious and open.
curious and open,
So,
but honest, and
Yeah.
and in when I started my training, everybody went into psychoanalysis. I know that sounds weird today, but
wow, different time.
it was a different time, and you didn't have to go into psychoanalysis, but you did have to be in therapy. That was as long as it was psychodynamically oriented psychotherapy. I actually worked with, when I was a fellow at University of Pennsylvania in child guidance, one of my mentors was Tim Beck, the father of CBT, and by the way, he was a really, really wonderful man. He was Betsy, did you know Tim Beck?
His once, and he was way beyond just CBT, wasn't he?
Oh God, yes. He was, and he was the ideal mentor. If I were going to be a mentor, I would want to be Tim Beck. He was smart but caring and interested, and when you're sitting with him, you just wanted to change your ideas because he was so good at connecting with you and being real, and so. That's a tangent. I got off. I got off the track there. Bring me back, everybody.
Thank you. It's just so great hearing about your process and ideas about kind of the mentorship in both directions. And without giving away too much of the plot line, because I know several people haven't read it yet, I found myself, one of the many parts that kept me just very intrigued in reading was that plot line of one of the mentees that you followed throughout, having some pretty significant interpersonal challenges, and seeing how you delicately provided support, but without still very much meeting her where she was at, and kind of letting the train wreck unfold a little bit, which was challenging for me to sit with, but also I appreciated that that mentor-mentee relationship, that you were so protective of that space of kind of letting her find her way while also providing support and guidance. So certainly hope to try to model even a tenth of that, if I can try.
But Nora, one of the things that you're bringing out is that it's important to remember that supervision is not therapy. There are aspects in supervision which begin to feel like therapy sometimes, but it's important to remember that you have limits as a supervisor. You have there are lines you don't cross, but that doesn't mean that every human interchange has this capacity for people to grow from one another, and the mentor-mentee relationship certainly has that capacity. There's a temptation, if you've been doing a lot of therapy, to treat everybody like someone who came to you for therapy. But mentees are not coming for therapy, they're coming for growth. But there's a little bit of overlap between therapy and growth. Hopefully, anyway, I hope people see that similarity. So what you're referring to in the book is that the mentee has to deal with her own issues, but you've been in supervision with people, and you find out that they're going through difficulties. I mean, it's a normal part of it. A mentor-mentee relationship is a human relationship, and if you're going to be in a relationship with somebody, you're going to end up sharing parts of you that you feel like you can share. And when you do that, you're expecting something in return. You're expecting someone to come back to you with some honest, hopefully helpful, supportive, caring responses. So your point is the supervisor relationship is not therapy. But boy, there are times when you can be human with your mentee and be helpful to them. And one of the this won't be a total spoiler, but as the mentee is learning how to ask circular questions in my book, she finds out that the therapist can't help himself. He's going to ask circular questions even in the supervision context. So and circular questions are not orders, they're not instructions, they're not dictates. They are invitations to think about things in a new way, invitations to add threads to your narrative, invitations to open doors. So, and isn't that what we do as therapists? The difference between the task of a therapist and that of a mentee, and that of a supervisor, is that the person coming from therapy is accepting a different helper-helpee role, whereas the mentee is accepting a teacher-student role. And those aren't necessarily there is some similarity in the dynamic, but they're different. They're clearly different. Am I running on too long here, or are you still engaged in what I'm trying to say? I hope so.
No, that's really helpful response. I think, you were saying like everyone was in analysis or in their own therapy. Like I think these days that's less so the case. So I think there is more sort of opportunity for that blurring, because many of these mentees, maybe it would benefit them to be in their own therapy, but they are not currently. So maybe the part of the supervisory space can be to, gently make that recommendation.
Yeah, I think that's totally appropriate. I think that's always been appropriate for those of you who've been supervising for a while. I'm sure there have been times when people bring to you issues and they want to cross the line. They want to use you for therapy. And your answer is, this is really an important thing going on in your life. And it may be beyond the context of what we're doing here. What would be a reasonable place for you to begin discussing some of these things? And I've done that. You've done that. Recommended that people get their own help. And I don't see I don't see a downside to that at all. And I think it can be done respectfully and comfortably with most of the people we're dealing with, because people don't get into this profession blindly. They self-select. They come to us because they are in the business of wanting to help people, and that means, gee, maybe I might want to get help too. It's not a very big step to take.
So
How about some people who haven't read the book? What would you like to know that I can tell you? Oh, by the way, I wrote this thinking that supervisors are going to start their year. In fact, I'm trying to do that with my supervisees here in Washington. I recommended before my first session, please read my book. You'll be 5 steps ahead in terms of understanding how to Nora, I know you bought that notion. I really think that it's an entertainment. It's actually a fun book. Most people say it's a fun book to read. It's got enough things to keep your attention, but it's instructive. It's written from this perspective of somebody who is immersed in family systems theory and practice, and so my whole goal as a former co-chair of the family committee was that everybody in the family committee would take it home and give it to their trainees and let them have a head start in learning about how life as a child psychiatrist can be. I had I don't think this is violating any privacy, but you all know Greg Fritz, who was my chairman at Brown for many, many years and former president of ACAP. His daughter-in-law is a very accomplished PhD in comparative literature who decided to go back into psychiatric nursing. And she just wrote me an email saying, Greg gave me your book and I read it, and then I read it again. And this is the kind of nurse practitioner, psychiatric nurse practitioner I want to be. They're just teaching me about drugs, and I don't need to know about drugs, but I want to know how to talk to people. And I thought, oh yes, that's the response that I would like to hear from students and supervisors around the country. Okay, I'm babbling
I'll tell you
again.
that this will be a required reading at University of Chicago for family course, so for sure.
Good. I like to hear that.
Yeah.
That'll sell 3 more books.
I'm really excited to pick up this book as well. I think one of the questions I have is just, of all the pearls of wisdom and teachings that you offer through the conversation, is there one above all that you really hope the readers to walk away with and, take on with them?
Well, I have 2 major themes in the book. There's several minor themes, but one is that what goes around comes around. People live in cycles that and this was actually taught to me way back when I was learning to do individual therapy. If somebody wants to deal with something and they don't want to deal with it today, just wait a few weeks, they'll bring it back. And people repeat themselves. And it's important to understand that. And the other theme is everybody wants to change and nobody wants to change. That people come to us saying, I'm miserable, I've got to do something with my life. And at the same time, they understand that change is difficult. Change is one of my teaching pearls is that if we can introduce a 2% change in somebody's life, that's a big deal. That's a big deal. I mean, let's not ask for religious conversion or something that's going to be earth-shattering. If we can get a 2% change in somebody's life, and you extend that for a year or 2 or 3 years, it can be life-changing. And so we as therapists should set our sights realistically. We should say that people want to change, and we're there to help them change, but let's not have expectations that are unrealistic, either for me or for the people we're working with. I guess that's those of you who've read the book. Does that come across? Is that something that you've really taken in? Nora, Betsy, Khalid, Khalid's in the middle of it.
That definitely comes across. And along with that, in parallel, one of the most stunning things to me is the extent to which you trust the family, that they can figure some things out. That is a large hurdle for trainees and supervisors, speaking for myself, to overcome. To just say, believe, well, you guys can figure this out. I'm here to help you.
Mm-hmm.
That's a bastardization of the actual concept. But I mean, I think it feels like that to a lot of my trainees, that they feel they have to come in with answers. And
well, people think we're there to teach people. We're not there to teach people. I mean, one of the takeaways that I from my own training, I think it was Jay Haley maybe who said it, you never tell anybody something they don't already know. They already know. I mean, should I start drinking? Yeah. Stop drinking? Yeah, I know I should stop drinking. I already know that smoking's bad for me. And, I already know that if I eat too many carbs, I'm going to gain weight. And people know I shouldn't treat people the way I treat them. You never tell people something they don't know. So why are we thinking that we can teach people something? Now, I have trouble with my psychologist friends with this, and I'm looking at one over here. They think that they know how to train people to be good parents. I don't know how many parents I've asked, do you know what happens if you give in to your child who's having a tantrum? And they say, they're going to have another tantrum. They know. It's not like you can tell them, don't give in to the tantrum. They know. The question is not the knowledge, it's the how. It's the how to do it. It's not the what. So yes, our trainees come in and they think they know a lot, and they think they'll say, give me a paper and I'll read it and then I'll know. And they do know a lot, but they don't know everything. And the people they're working with know a lot too. And so I think your point is well taken, Betsy, that I don't think that we teach people. I think we enable people. We support people. We open doors for them. We add to. We join with them. One of my images in the paper is one I've gotten from chemistry, which is that in that we function like enzymes. We connect with complex systems and distort them a little bit so they can add something to their life, like complex molecules in the body, and then we distort their story and open doors for them, and then we leave. And it's their job to fill in the blank. It's their job, once the door is open, to either add something to their life or decide that's what they want to do and to hell with you, which is a common enough experience that we've probably all had.
So I have a question. So when we are writing a paper, specifically on a topic or trying to explain something. How did you decide what to include in this book? Because with your experience, with your own supervision, with supervising so many, how did you decide what was like so important that should be included in this book? How, like, was it natural as you were writing, or was it a very thoughtful
Well,
kind of?
that's a good question, Khalid. People who've been in supervision with me, when they read the book, they say, "Oh yeah, we talked about that years ago." Because so some of the stuff that shows up in the book has been part of my repertoire, my supervision repertoire for many years. But if you read the book, it becomes pretty obvious that just as the trainee enters the supervision session with a certain naivete, being a CBT person, she doesn't really want to talk about her family. She's kind of cold to the idea of having a lot of people in the room. The first family we see together is the easiest family to deal with. It's an acting out child, it's a teenager. I'll tell you this, anybody who's read 10 pages, it's a teenager, a 14-year-old who wants to go sleep at her boyfriend's house. And so as you go through the book, the cases become more complicated, just as the training becomes more complicated, just as the ideas that we deal with become more sophisticated. Simple ideas at the beginning of the book, more complex in the middle, and by the end of the book, we're dealing with some fairly significant abstractions that I think are important for people to take away. In the first case, the trainee and the supervisor are able to understand that the parents are giving the kid totally opposite messages, and she's picking the message she wants to hear, and actually she wants them to be united. I don't know how many times I've asked teenagers, would it be better if your parents disagreed with how to treat you, or would it be better if they agreed and just let you know what they really want? And I can't tell you how many teenagers have told me, "Oh God, I wish they'd just agree, and then I'd know what I'm fighting against. Then I'd know what I can rebel against." And there's another example of you never really tell anybody something they don't already know. So the answer to your question is the examples that I picked. They're a smattering of the things we see in child psychiatry. There's all of the major subgroups. There's some alcohol abuse. There's some domestic violence. There's medical child abuse. There's so a little bit of everything. But it's, I guess, as I was, and people who are interested in the process, when I started this, after deciding I wanted to write a novel and deciding what the format would be, I wrote down a list of problems that I thought child psychiatrists face, and then I started dictating into my computer. The narrated family sessions were the easiest part of all. They were the easiest things to write because you've heard these stories. I've heard these stories. The language, I had to really work at making the language less clinical and more matter of fact, because like most of you, I have an internal monitor that translates everything into clinical language, which doesn't really help on the page if you're writing a novel. But the stories of the sessions, that was the easiest part to write. We've been here almost an hour. I'm just getting warmed up. I don't know what I know this is lunchtime for many of you, so it's anybody want to have any, should we conclude? I'm willing to. I'm sitting here on my island. I have nothing to do for the rest of the day.
I do
What
have
other
to
things?
step out because of the hour, but I do want to thank you, Tom, and I ordered the book while we were, it's on its way
Good
to
for you, Andy. Good for you.
Thank
And
you.
think about it for your trainees. That's what and Nora and Khalid have done, because I think that and Betsy. So because I think that if you read it, it doesn't. Everybody doesn't have to like it. I mean, you can say, "Oh boy, this is a swing and a miss." But on the other hand, most people have given me good feedback. So if you have good feedback and you want to share it, that would be a good thing, because I think it has some merit as a teaching tool. I think it has a supervision tool. I wrote it for supervisors and supervisees and for myself. Final thoughts, people. Anybody? Yeah.
I think
Hi.
it. Go ahead.
Sorry. I joined late. I'm sorry. I had a meeting, but I don't know if you remember, but I met you actually at the family therapy boot camp at ACAP. And so I really did appreciate some of your comments about and learning from you. And so I'm pretty excited to read the book, knowing how much I learned from just your thoughts when we did the small groups and going
I
through.
remember you. Sure. Oh, good to see you.
Yeah, so I think I'm pretty excited to read it, and I've ordered the book, but it's on its way. So
Okay, that's good. Other thoughts, Chen?
No, I'm definitely going to be picking it up, and I think it'll actually be a really good tool because here I work in different capacities. I mainly run a PHP, but also do a lot of fellow teaching and clinic, and I think what I do is a lot of family work with all the kids that we see in the day treatment program, and so not just with the fellows who rotate through, but also with the therapists. I think sometimes helping them know where to start. And I think they're always asking me, is there like a resource or something, and short of telling them, right, and all the trainings that they go to on family, I think this is a great resource. So thank you so much for writing this.
Thank you.
Yeah,
Thank you for ordering it, and I hope you like it.
Absolutely. I'll be sure to let you know how it goes.
And by the way, I would be Khalid. I know this is an ongoing event for ACAP, and I'd be happy to host again if you invite me. But
We would love.
I know Michelle is way up to the task of and Khalid of keeping this going. Other thoughts?
Yes, I think Betsy had a comment.
I just realized a wake-up call for myself, which is I have to stop thinking of myself as being hired to teach the trainees, but rather to enable these young people. Duh! It's so easy to fall back into the mode because the system is so, and they come in saying, teach us, we don't know what to do, teach us. And being helpful, I fail to hold back and say, you know how to do this. I mean, I do find myself saying, look, family therapy is not rocket science. You don't have to go to, a NASA equivalent and be trained. You know this stuff and what you have to do. So
you live in families. You've always lived in families. You interact with families all the time, and use your common experience, but be honest with yourself. And
I can say that, but I get sucked into the system, to the medical model of thinking that I have.
We all do. I mean, it's a constant issue for all of us. Don't beat yourself up, Betsy. That's okay.
Thank you so much, everybody. Thank you for joining.